Okay, so this is the second part of chapter 7, which is on the axial skeleton. Axial skeleton is the part of the skeleton that kind of goes down the middle of you. The skull, vertebrae. We'll go over that somewhere along in here. Okay, so for right now, we're just kind of on the skull, finishing it up. I talked about the ethmoid bone a little bit. This is that second bone that's all they show an exploded view of. I think the important parts of the ethmoid bone are the perpendicular plate that goes up and down between the two halves of your nose, the crista galli, which sticks up into the up into the brain, and keeps it from sloshing from side to side, and the cribriform plate, which is a whole bunch of little holes along here in this plate that you can see easily when you look down into the skull, where all of the olfactory nerves go and connect up to the olfactory bulb, which is what carries your sense of smell from the top of your nose up to your brain. We'll come back to that, obviously. So here it is. Here's where that cribriform plate is, right here. A bunch of little holes right along in there. We have a couple of rill skeletons, rill skulls, over in the lab. And if you look at the rill skulls, you can actually see the holes that are right along here. Unfortunately, in the plastic skulls, because these are so tiny, you don't really see the hole. It's just a little dimple where the hole should be. This is a way of looking at the cranial floor. Posterior cranial fossa back in the back, the middle cranial fossa is on both sides, and the anterior cranial fossa up front. I'm not sure what that really adds, but anyway. Let's talk about sutures for a bit. Sutures are pretty easy, especially after you learn the directional terms back a ways. The one that goes down the middle of your top of your skull is called the sagittal suture. Expect that. Sagittal slice goes right down through the middle of you. And it basically divides the right and the left parietal bones. Please notice that it's very crooked, and I guess that gives it a little more strength. There's no real rhyme or reason for that, though. So here's the frontal bone up in front, here's the nose down here, and the occipital bone back and back. The other sutures are the coronal suture. The coronal suture, remember the coronal plane that goes this way, also called the frontal plane, but this suture is called the coronal suture. Enough said. The squamous suture is between the parietal bone and the temporal bone, and it's called that because this is a very flat area of your skull. The squamous area, called the squamous suture. And enough of that. The suture in back between the parietal bones and the occipital bone is called the lambdoidal suture. Now it comes up on one side and back on the other. Back there, I think we have another view from the back. And the other thing you should know is that there are little extra bones in your skull, usually back here in the back, where those sutures become so contorted that they actually make they actually create a new bone in between there. There's nothing significant about them. There's no names for them other than just sutural bones or wormian bones. That's it. I'm not sure why we even show this slide, but it makes everybody happy, I guess. It's important you know that your skull, when you're a baby, is not very developed, and these sutures are certainly not sealed up together. That allows lots of room for your head to get bigger, and because our head grows tremendously in babies, and it's not till a little later that these sutures become fused, and then it becomes a solid case of bone around your head. I'm sure that's not up until you're in your 20s when it's finally totally connected. So anyway, here's your coronal suture. Here's your squamous suture. Here's your lambdoidal suture. Notice that this picture labels several different fontanelles. A fontanelle is a soft spot. It's where several sutures come together. I don't expect you to know the names of any of these. The sphenoidal, except for one, we'll get to in a minute. The sphenoidal fontanelle is over here on the side. I don't know. Mastoid fontanelle, I guess if you feel around on a baby's head, you could maybe feel that one. But just know that all of the sutures, the squamous suture, the coronal suture, and the lambdoidal suture, you can probably feel all of those on your baby. It's soft. This is the one that I think is important, is the anterior fontanelle up in front, right up here on the baby's skull. That's important in the assessment of children, that you feel that. So when you're doing an examination on a baby, you want to you'll be feeling that, and if it's bulging out really hard, it means the kid's either screaming or they have high pressure in their head. If it's really sunken in, it usually means the kid is dehydrated, and a lot of babies, of course, go through periods of vomiting or diarrhea or anything like that, and they get dehydrated, and that's a good assessment. Just by putting your finger up there in a baby up until about 6 or 8 months of age, you can feel that pretty well. But trust me that if the kid is crying, it will be bulging out. Here's the orbit. I think I mentioned to you before that there's 7 bones that make up the orbit. You probably ought to know these. Once you get the skulls in your hand, they'll become pretty obvious to you. We've gone over, I think, most of these bones. If not, we'll see. Anyway, the frontal bone makes up the upper part here. The lacrimal bone is over here by the tear duct, where the tear duct leaves the eyeball and goes down into the nose. The palatine bone is a little yellow one back here. The sphenoid bone we talked about, and it's the purple one here. The zygomatic bone makes up part of the orbit, as does the maxillary bone. The maxillary bone is the one that makes up your front of your face and holds your upper teeth, as we're going to talk about now. So here's the maxilla. It's this orange one here. The things to know about the maxilla are that it forms the hard palate, and if you put your finger in the top of your mouth, you'll feel your hard palate. And if you walk your finger back in your throat, in your mouth, you'll actually hit this bone here, the palatine bone, I believe, and then this one here called the vomer. And then as you keep walking back there, it'll get really soft, and there is no more bone, because the palate actually extends back to about this level, back in about here, up in your mouth, and that's the soft palate, which is just muscle, which you can feel if you put your finger in the back of your mouth and feel the roof of the mouth. So the maxillary bone, as I mentioned, serves as the sockets for all of your upper teeth. All of your upper teeth are stuck in your maxilla. This hole right here is called the infraorbital foramen. Makes sense. Right below the foramen, right below the orbit. Let's talk about the mandible. Mandible is the jawbone, and it has several things you need to know about it. First of all, it serves as the place where your lower teeth all insert. So all of your lower teeth sockets are in the mandible. You can divide the mandible into a body, an angle, and a ramus. On the outside, there is a mental foramen up here. I think we talked about this being the mental area, the thinker, the front of your jaw. It's the mental area. Then there's 2 prominent sticky-uppy things over here. One called the coronoid process. And the coronoid process is the place where a number of your masseter muscle and your temporalis muscle insert. So if you bite down real hard and and you feel these muscles up here, even above your zygomatic arch there. That's your temporalis and your masseter muscle, and they insert there on the coronoid process. The other sticky uppy thing is the mandibular condyle here, which is where the joint is. That's what your jaw rotates on, and it sticks up here into the mandibular fossa. Remember that? Which is part of this red bone, which is called the temporal bone. And so this is the TMJ, the temporomandibular joint. If you look at the mandible from the inside, there's a couple other points that you should know. There's a little line across the jaw on the inside here called the mylohyoid line. That is where a number of muscles attach. You know, the bottom of your chin under here really doesn't have anything strong in there. It just has a bunch of muscles that kind of create this whole area. And those muscles, most of them go back and hook into the hyoid bone. Remember the hyoid bone? It's kind of floating free back in here somewhere. And a number of muscles run from your mylohyoid line here back to your hyoid bone, and basically are what consists the bottom of the floor of your mouth and your lower cheek there, I guess you'd call it. There's also a big foramen that runs along the backside of your inside of your jaw here, called and an opening into it is the mandibular foramen. And clearly, if you've ever been to the dentist and had teeth work done on your lower teeth, you know, and he goes back in there and open eye, and he's shooting for this area right here. Because the nerves run through there that are going to go to your whole lower jaw and your teeth. And so if he can put numbing medicine in around there, he'll numb up your whole lower jaw and your teeth so he can do his deed. I mentioned earlier the palatine bone here. The palatine bone is this yellow one. It just is a pretty small bone. It forms part of the orbit we just saw. And it also forms part of the back part of the top of your mouth, your palate, your hard palate. Just behind it is this other bone called the vomer. The vomer is an unpaired bone. In other words, there's not two of them, a right and a left. There's just one of them. There it is right there. It forms the very back. It just, like I said, even behind the vomer, there's the soft palate, which is just muscles back there. Zygomatic bone, we haven't talked about. We talked about the zygomatic arch when we were talking about the temporal bone. And remember that the zygomatic arch and the temporal bone form the zygomatic arch, formed two bones. You know, there's a bunch of really stupid guys that go out and get in fights in bars, and when you punch somebody in the face, the thing you're most likely to break is their zygomatic arch here. And if you break that arch and push it in with a good strong punch right here, the person will not be able to open and close their mouth. Because remember, these muscles that go to your coronoid process here that make you bite run behind that arch. So if this bone is sticking down into that muscle, they can't open or close their mouth. And so they got to go into the operating room after they sober up usually. And the ENT doctor usually takes a screwdriver or something and lifts it up, tries to get it put back into proper position. So there's room behind it for those muscles to work so these guys can eat again. Although I'm not sure that's really, just leave them like they are for about a month. Let them think about it. But we don't do that. The facial bones, so basically we've talked about them all by now. The maxillary bone is the upper jaw or the upper teeth. Zygomatic bone, vomer's back there in back. Nasal bone, You notice that the nasal bone is really pretty small. You know, a lot of people will say, "Oh yeah, I broke my nose," and they really didn't break their nose. They really broke. They didn't break their nasal bone, at least. Most of the time, they just broke their cartilage. Because most of your nose, the thing that makes your nose stick out the way it does, is cartilage. So, and that extends, you know, out to like this. So from here, from this little bone out, it's all cartilage. So, you know, another guy gets in a fist fight, he gets his nose pushed over to the side. It's just cartilage probably that's been broken. I mean, they'll x-ray to make sure. But, you know, usually all the doctor does is push it back over into place, slap some kind of bandage on there and tape it really good so it holds it there sort of in the midline, and they do just fine. Not that the cartilage really heals, but the tissues around the cartilage called the perichondrium heal. Kind of hold it there in place. The concha, I've already mentioned, inferior nasal concha. Notice that it comes from the blue bone. What's the blue bone? This one out here, zygomatic. And the upper two come from the ethmoid. The green one is illustrated here. They serve to stir up the air as you breathe it in. You'll learn more about that when you get to 233 when you talk about the respiratory system. And the perpendicular plate, you've heard of people that have a deviated septum. That's what they have as a deviated perpendicular plate here. And one of the things that unfortunately we see relatively frequently now with a lot of cocaine use and people snorting cocaine is that a lot of those folks, cocaine is a very strong vasoconstrictor. It makes the blood vessels shrink down really small. And so this piece of bone here in the middle of your nose tends to die. It just doesn't get enough blood supply because the bone is continually, the blood vessels are continually shrunken down and constricted. So a lot of times people will have a hole in their nose, or not really a hole in their nose, but from one side to the other when you look up in there with a scope. Just one more stupid reason not to snort cocaine. If you're gonna, I won't say this, just shoot it IV. Go on and kill yourself and be done with it. But snorting it really is pretty hard on the inside of your nose. Don't quote me on that. The sinuses we've mentioned a couple times before. Here's just kind of a review of them. There's several of them. The sphenoidal sinus is the one I told you I had the problems with. The frontal sinuses are probably the most common ones that give people troubles. Those and the maxillary sinuses. And you see these pictures on these ads on TV all the time about, that kind of draw out these maxillaries and frontals, and they're red, and they all that stuff, and you got to take this drug to dry up your sinuses. The sinuses are just air cavities. They're lined with a mucosa, though, and so that mucosa is always making some mucus, and if the little drainage hole out of the sinus gets clogged up, then the whole sinus gets clogged up and fills up with fluid. When it fills up with fluid, then it can go under higher pressure than normal, and then it's sinusitis, and it's pretty painful. Can be pretty painful. Okay, well here's that picture we started with. We learned about the skull, and let's see if we've learned anything from going over this skull business. Maybe you can tell me some things you see now that maybe you didn't see before. You can see the coronal suture, yeah, sort of, right down through there. Very good. What did we say this hole here was? Yeah, and what do we call that in A&P? Besides ear hole? external auditory meatus. Okay, you notice right back here behind the external auditory meatus, there's kind of a bunch of dark areas. That's air. That's air in the mastoid air cells, or the mastoid sinuses. They're not really sinuses. They're just little pockets of air that are in the bone back in there. And that's what you're seeing right there. What's this pointy thing back here on the back of the occipital bone? External occipital protuberance. A bunch of muscles are attached to back there that pull your head back, run down the back of your neck back here. And we said this is what? That's the little Turkish saddle. Remember that? That's the sella turcica. And the little hole in the middle of it is called what lives in there? Pituitary, or the hypophysis. The hypophysis is another name for pituitary gland, so it's called the hypophyseal fossa. Fossa. Makes me think of the Lion King, Mufasa. So what's this little bone that's sticking up right in there? Maybe the Crista Galli. Remember that one? You don't? So there's a bone that's running this way, and it's all in through here, which would be called the perpendicular plate, right? We said frontal sinus. We can now say ethmoid sinus. We can say frontal sinuses are in here, but it's kind of hard to figure out what's really sinus and what's just simply in your nasal cavity as far as the air, the dark areas are concerned. So this is your mandible, and you can sort of see the little fossa, the little groove that runs along the back of it there, which is called the mandibular foramen. That's right. And there's this little sticky uppy thing right here, which is called the, well, it goes up here to the TMJ. The TMJ is right in here, the temporomandibular joint. And that sticky uppy thing is called the condyle. Yeah, mandibular condyle. Condyle is a prominence of a bone. And then, so that means this one up here comes right up in there like that, would be the coronoid process. Okay. Here's the hyoid bone down here. I don't know if I mentioned that last time. The hyoid bone is kind of an odd duck because it doesn't touch any other bone. It just hangs out there in space. And the hyoid is touched by a whole bunch of muscles that just kind of hold it and keep it suspended there. The muscles we talked about from the inside of the jaw over here run to it, and so forth. What's this little bony thing, this little spiky thing coming down there? Might that be the styloid process? Okay, let's finish up the axial skeleton. The axial skeleton is axial. That means it's the stuff in the middle. Okay, we're gonna divide the skeletal system into two parts. I don't know how important that is, but nonetheless, that's the way the book teaches it. And so we have an axial skeletal chapter, and then we have a appendicular skeletal chapter. So that's the appendices, or the arms and legs, basically. So the axial skeleton contains more than just the vertebrae and the skull, but those are the two main things, the skull and the spine. It also includes the thoracic cage, in other words, the ribs, cartilages and the bone in front, which is called the sternum. That's right. And the last one is that little hyoid bone that I mentioned to you that's sitting up there high in your neck. You ought to check out the hyoid bone on our skeletons over there because they just kind of have it wired so it sort of sits there in space. But that's really the way it is. Now, let me just make one more point to you because it seems like you'll probably be asked this. Please notice, when you look at this picture right here, that the pelvis is both. In other words, the spine, these are the lumbar vertebrae, and this is called the sacrum, okay? And at the bottom of the sacrum is a little bone, a couple little bones called the coccygeal bones, or the coccyx, okay? Those are part of the axial skeleton. But the rest of the pelvis, in other words, these big guys around that form the rest of the ring here, those are part of the appendicular skeleton. They are basically the support for your hips, okay? So just keep that in mind. It's just a technical thing. Leave it at that. Let's talk about the vertebral column, and that basically involves all the vertebrae. And here's a couple of numbers you're just going to have to learn. There are 7 cervical vertebrae, number 1 through number 7. So the top one is called C1, and the bottom one is called C7. Then we go into the thoracic vertebrae, and the thoracic vertebrae go from T1 to T12. There are 12 thoracic vertebrae. Now, the way to know whether it's a thoracic vertebrae or not is to see whether or not there's a rib attached to it, because the 12 thoracic vertebrae each have one of 12 ribs attached to it. Now, that fairy tale that you read about in the Bible about how they took a rib out of Eve or Adam and turned it into Eve, and a lot of people think men have one less rib than women. That's malarkey. Everybody has 12 on each side. Okay, so we all have 24 ribs. It's just a story. Okay. Then we have 5 lumbar vertebrae down here. The lumbar vertebrae are really big. They're the ones that give probably more people problems because they have to support basically the whole body almost. And then below that is the sacrum. The sacrum is nothing more than 5 more vertebrae, but they're all fused together into one bone called the sacrum. And then below that is the coccyx down here. And I don't know what we counted. I think we counted as 3 coccygeal bones. So you need to know about the spinal curves a little bit. And it's kind of interesting if you think about it, because the cervical curve is what we call concave posteriorly. In other words, from the posterior side back here, it's concave. It kind of goes into a cave, right? Which means it's convex from the front, right? And then they just alternate. So the thoracic vertebrae are concave from the front. See, it swoops this direction. The lumbar vertebrae are concave from the back, and then the sacrum is concave from the front. Okay? Now that doesn't mean this person is all humpbacked or anything. That's a normal setup right there. Okay. Primary curves they're present during fetal development. I don't know how important that is. I don't think it's important. I'm not going to ask you about it. What's the difference between a primary curve and a secondary curve? But I do think it's important that you notice that you know which ones are concave posteriorly and which ones are concave anteriorly. So let's talk about the vertebrae now. And these guys are pretty simple, I think. But then I've been over this a few times. There's 7 of them. Okay, there's 7 cervical vertebrae. There's 12 thoracic vertebrae. The thing thing that's cool about the thoracic vertebrae is they each articulate with ribs, and then there's 5 lower vertebrae. Sacrum and coccyx. The sacrum is basically sits right below the 5th lumbar vertebrae, articulates with the coccyx, and then the coccyx articulates with the sacrum, articulates with the coccyx at the very bottom. Articulate means connects, kind of a joint in between. They touch. You might say they touch. That's what articulate means. A lot of people have weird backs. This is called kyphosis. This is the hunchback kind of picture where it's way too curved. Lordosis is when it's way too curved the other way. So instead of sticking out a normal amount, it sticks in up here in the thoracic level. Scoliosis means it's curved to the side. Okay? Now I can promise you that nobody has just one of these. Nobody has just scoliosis or just kyphosis or just lordosis. Basically, people have either kyphoscoliosis or they have lordoscoliosis. Okay? Because if your back is bent over that much, you can bet it's going to twist to one side or another. And what do you think the biggest problems are that these folks have? What?
Do they, when they fix it, do they put the vertebrae straight?
They do try to fix it sometimes. Yeah, it's a horrible surgery. It's a big, big surgery to fix that. But the biggest problem these folks have is breathing. Okay? You and I, with relatively straight backs, can breathe and pull our ribs out and take a deep breath. These folks really can't. So their exercise tolerance is really low. They can just only do so much. Let's talk about the basic structure of a vertebrae. Now this is just a basic structure of all vertebrae. All of vertebrae have these kind of these basic characteristics. They all have a vertebral body. I'm going to kind of draw a vertebrae over here and say that they have a body down at the bottom. And then they have a vertebral arch. This is the posterior side. So this is the dorsal side or the posterior side. And so they all have an arch. Kind of comes up and goes across and comes back down. I'll just leave it like that. They all have articular processes. Now, by that word, articular processes, what do you think that means? They have articular surfaces, where they articulate on each other. So one vertebrae and the one on top of it articulate in several places on these articular processes, so to allow a little bit of movement between each of your vertebrae. If we didn't have any movement between our vertebrae, we would be stiff. But we can bend over, and some of you are a lot more flexible than me, but that's because your articular surfaces haven't cramped up as years go by, I guess you could say. So, this part down here is called the vertebral body. Between one vertebral body and the next vertebral body is always a disc, a vertebral disc, which is a little shock absorber between each of them. You don't really see it here in this view, but one would sit here and one would sit below the thing. This is the arch back there across the back, and it's made up of a couple of parts. This part over here on the sides is called the pedicle. Vertebral pedicles. And then across the top, draw it a little bit differently. Let's draw it kind of like that. This is called the lamina. The lamina, which isn't even drawn in on that picture right there, but that's okay. Coming out the back, is called the spinous process. And then, I'm not going to draw this in on my picture, but just to show you, these little things right here, see that little smooth area there, and this one here, and then there's one you see on the back side back there, and there's one right there on the back side as well. Those are the articular processes and the articular surfaces. In other words, those are where the joints are. So the vertebrae above here has a little thing that sticks out here and articulates with that and with that. And the one above it on the other side articulates with this and with that. I wish I had could have vertebrae in your hands right now, but anyway, that when you get your vertebrae, look at them, you'll figure that out real easy. They pretty much all have transverse processes out the sides. And what do you think runs through here? The spinal cord. So the whole idea of the spine of the vertebrae really is to protect our spinal cord. Because if we break our spinal cord, we're paralyzed from that point down. So it's pretty important. And that's what all this bone is about. It's bone that protects the vertebral column, the spinal cord. It lives in this hole, the big hole here called the vertebral foramen. Just a kind of a side view of the same thing. The arrow passes through the vertebral foramen where the spinal cord comes down. This is the spinous process sticking out the back, which I drew in up here. Here's the transverse process coming out the sides. And here's some of these articular facets or arteria, and they're hanging off of these articular processes, which is the bony thing that's sticking out. The smooth place on the end is called the facet, F-A-C-E-T, or joint. Transverse processes there. Here's what, if you add the discs in, it looks like this. So here's the intervertebral discs right here and here. That's basically it. These guys here are made out of fibrocartilage, that's right.
How about the superior articular basis? Is it fibrocartilage?
No, it's hyaline cartilage. All the joints in your body are made of hyaline cartilage on the surface. Good question. Okay, so they're numbered from 1 down to L5 is the bottom one. C1 articulates with the skull. I told you there was a special name for C1. Atlas, right? Atlas holding the world. So C1 articulates with the skull. L5, lumbar 5, articulates with the sacrum down at the bottom. This is what you need to know. You need to know the difference in the different regions of the vertebrae. You don't have to know the difference between T8 and T9. Okay, you just need to know that it's a T. Okay? You don't need to know the difference. You do need to know C1 and C2 because they're very different than all the rest. You got to identify those. But all the rest of the cervical vertebrae are about the same. So C3, C4, C5, C6, and C7 are all pretty much the same. They have all the same characteristics. So what I want you to learn here is the characteristics of each region. And the reason they have different characteristics is because they have different functions. Okay? Some of the vertebrae at the top, it's really important because they do this. They allow you to turn your head. Another joint makes you be able to do this. Your neck, the vertebrae in your neck, all they have to support is your head. Not that your head isn't big, but it's not like the ones down in your lumbar that have to support everything from there up, both your abdomen, your chest, your arms, your neck, and your head. So the ones down at the bottom in the lumbar vertebrae are going to be a lot stronger and heavier duty. There they are. Let's talk about the cervical vertebrae first, because remember they're kind of small because they only have to support the head. They have a very large vertebral foramen. Well, think about this for a minute. If you got this brain up here and it's sending all this information down through the spinal cord, the spinal cord is going to be a lot bigger up here at the top than it is down at the bottom, right? Because this part of the spinal cord up here has to carry information to the entire body. Whereas once you get down to this level, it's only got to be carrying information to your legs, for example. Okay? So your spinal cord is going to go from big to smaller, with a couple little exceptions. The size of the vertebrae, because of the weight they support, is going to go from little to big. Okay? The atlas has no spinous process. The atlas, C1, is the only one that doesn't have a spinous process. Out of all of the vertebrae in your body, C1 is the only one that doesn't have a thing sticking out the back of it. The other thing about the cervical vertebrae from C2 to C7 is that their spinous process is bifid or bifid. Okay, so it's not just a little thing sticking out the back like this. It is bifid. It speak with forked tongue. Okay, like the snake has a bifid tongue. Here's what they look like. Here's the cervical vertebrae, C1 through C7. Notice, well, you can't really see it so much there, but you don't really see so much that there's not a posterior spinous process, but there isn't. Here's what the rest of them look like. This is what's called a typical cervical vertebrae. Okay, in other words, they all have these different characteristics. Notice that the vertebral foramen is relatively big, because remember the spinal cord is relatively big up here. Overall, though, the size is smaller. So here's the posterior side. This is the spinous process, and notice that the spinous process is bifid. Okay, that's the biggest hint for you that what you have in your hands is a cervical vertebrae, if it has the bifid spinous process. The other biggest hint is that the cervical vertebrae are the only ones that have this extra hole out here on the side, called the transverse foramen. Now, we'll learn why we have those transverse foramen, but let me just say that the reason we have them is because the vertebral arteries go up through there to take blood to the brain. And when they do, they go up there, they're very protected within this bony structure here of each of the cervical vertebrae as it goes up. Now, just think about it. If you're trying to fight a tiger and he's trying to bite your neck, it'd be really nice if your arteries were protected by bone. Wouldn't that be nice? It probably wouldn't. You're right. But if it was a coyote, maybe it would. Yeah. And remember, your arteries in front, which are your carotid arteries, are actually the biggest ones. They're not quite so well protected, although they are behind a couple of layers of muscle here in your neck. You can feel them. Okay, so here's the pedicle. Remember, the pedicle is the part of the arch that comes up, and then this is the lamina of the they actually labeled it here, lamina, and then the transverse foramen down here. Okay. Here's the weird ones, C1 and C2. This is C2. We call the top one the atlas. C1, we call the second one C2. We call it the axis. Now, the reason we do that is the atlas holds the head. The axis is the one that allows, between C1 and C2 is where you turn your head side to side, basically. Up here on C1, on top of C1, between C1 and your skull is where you nod your head this way. Okay? So skull to C1 does this. C1 to C2 does this. That didn't go on the tape very good, but anyway. Now the funny thing about C2, and the thing that makes the axis very different than all the other vertebrae, is that it has this thing that sticks up off the back of it. And we think that evolutionarily, what this was this actually was the body, the big fat thing, this part, of C1. But in order for us to be able to turn our heads, we eventually evolved to the point where this part of C1 actually fused to C2, which then allows us to rotate our head between C1 and C2. Without that, we probably wouldn't be able to rotate our head more than about that much. So basically, this is called the dens of the axis, the dens, D-E-N-S. Has another name. I'll get it in a minute. Notice there's a ligament here across the front, and this is where most of your side-to-side movement goes, between C1 and C2. Here's an example of a cervical spine film that you don't want to be your cervical spine film, by the way. Here's the bottom of the skull, which is the occipital bone. Obviously, the foramen magnum, the big hole, is back right up in there. And coming back right along here is where the spinal cord runs. So this is the body, the front part. Remember, this part down here. And then here's the lamina. It comes up and then across. The pedicles come up. Lamina goes across. Here's the posterior spines, which you can see coming out the back. But notice there really isn't one here off of C1. Now, since I told you that this between here and here is where the spinal cord runs, okay? There. Oops, wait a minute, where is it going through there? Ooh, wait a minute. This bone here should be sitting on top of that bone there, right? So this person here has fractured their neck. They have broken bones in their neck. Their spinal cord, which runs right here, here's the bottom part of it, comes right up to here. Then it needs to go turn over and go up here, okay? When that happens, those two bones move across each other and generally sever your spinal cord. So this person is a quadriplegic, cannot move his arms or legs. When people fracture their neck at about the C4 level or above, they lose strength in both arms and legs. Not only strength, but also feeling. So this person is one of those folks that you've seen that are riding around in a wheelchair, powerized wheelchair, that have something that they manipulate with their mouth. They blow on it, suck on it, and usually turn it a little bit from side to side. That's a quadriplegic. All four extremities are gone. Now, if you break your neck and you break it down here at C6 or C7, you're probably going to still have some strength in your arms. Okay, so these are the guys that you see that are out there racing wheelchairs and stuff like that, because they build their upper bodies up so tremendous, but usually from their shoulders down, they're pretty withered away because the muscles don't get any exercise at all because they can't move at all because they have no spinal cord going to them. So this is a transverse film that we take in the emergency room anytime a patient comes in from an accident. And the significant thing is, whether you're an x-ray tech or a nurse or anybody, is you always want to make sure that you have all of the vertebrae, all of the cervical vertebrae included. 1, 2, 3, 4, 5, 6, 7. technically what you always want to see is you want to see 7 on 8. You want to see, or not on 8, but C7 on T1. You want to see this next vertebrae to make sure that there's no movement here. I would tell them to take another film. Let's get another film. This person we know has a fracture here. We're going to be really careful with them. We're not going to move their neck around because we don't want to make it worse. But that you can just pretty well bet that patient is quadriplegic with that much distraction of their vertebrae. The next level, not too many people break their neck or break their vertebral column below that because your neck is just kind of hanging out there, obviously, and it's easy to fracture your neck. And every time people get in car accidents and whip their neck forward, or if their head hits the glass, but a lot of times it's this problem here, and then a lot of the injuries come from this going back. That is what fractures their neck. It's really important. We have a wonderful safety device in our car that I bet none of you have ever thought about. It's called your headrest. When you get in your car today, I want you to sit down in your seat and touch the headrest. Your headrest should touch right at the back, most farthest back part of your head. Adjust it, and then just leave it there. If you're the only one that drives that car, it's set for you then. A lot of times I've seen people that are really tall and their headrest is all the way down. They never thought about pulling it up, even though there's a little thing, you just pull it out, you can slide it up. So set it right for yourself. It could save you a broken neck. That's a pretty big deal. Pretty well ruins your life. I had a student here that fractured her back at the T8 level. In other words, mostly down through her chest. It was a skateboarding accident, or not a snowboarding accident, where she actually went flying and hit a tree right across the middle of her back, and she was paralyzed from that point down. But she could move her arms really well, she could breathe really well, and she did fine. In fact, she made straight A's in A&P, and she's now a physician's assistant. She went through Pacific Physician's Assistant School and is working. She sent me a really nice note a few years ago. She said, I just want to let you know that I finished PA school, and today I picked up my diploma, and I also got married. She had gotten through school, gotten married, as well as finishing PA school. And the only accommodation we had to make for her was that when we did the practical exams, instead of putting the microscopes up on the desks, we put in a couple of extra tables this lower, so she could just roll up in her wheelchair and look. Let's see, she could lift herself up out of her wheelchair a little bit, but it made it. That's all we had to do. And outside of that, she did everything herself, and was quite amazing. Anyway, let's talk about the thoracic vertebrae for just a minute. T1 through T10. These guys have transverse costal facets. Now, what's a facet, remember? It's a little joint, right? And if it's a costal facet, what's a costal? Costal means ribs, okay? So these are transverse on their own sides. They're costal, that's where the ribs attach, and they're facets, so they're little joints. So when you look at your thoracic vertebrae, you'll see there's a little smooth area out there on the outside where the ribs attach to them. I think this is better to just look at when you have them in your hand. T1 through T8, they articulate with both pairs of ribs. They articulate with the one set of ribs above them and also with the one below them. So they have both superior and inferior costal facets. I'll show you how that works here in a bit. So here's an example of a standard thoracic vertebrae. Notice that the vertebral foramen is actually getting smaller. The spinous process is no longer bifid, it's just single. Laminas here, the pedicles are here. Here's the superior articular facet where it's going to articulate with the rib above. Here's a superior costal facet, and here's a transverse costal facet. Now, just so you know, the reason there's two of them is that the rib goes like this, and the end of the rib articulates with this, and then just up the rib a little ways, there's another facet, and it articulates with that. So the ribs actually attach in two places to those vertebrae. Here's what it looks like from the side. I think the most striking thing is how long and how big the spinous processes are in the thoracic vertebrae. Once again, here's one of those articulation points with the rib, and here's another one right here, and here's another one right here. So this one here this is one rib, it articulates here and there. This rib down here articulates here and with the next lower rib over here. Lumbar vertebrae are the biggest, thickest ones. They're oval. They don't have any costal facets because they don't have any ribs. The vertebral frame looks almost triangular down here. Biggest thing is they're just big. Here's an example of one. Big, thick old things. They do have articular processes because they do articulate with each other, but they don't have the costal facets. Notice that the vertebral foramen is almost becoming smaller and smaller down there. They still have the transverse processes. They still have the spinous processes. They still have the lamina. They still have the pedicle, the part that goes up, and of course they still have the vertebral body. I think we'll stop right there, and let me just do this little quiz right now. No, I'm not going to do that. I just realized that I don't have the PowerPoint with me. It's up on my computer upstairs. All right, so we'll do it at the beginning of lab. I'm sorry if you were getting excited. Okay, come on back down. Here we go. Let's talk about, we'll get through the sacrum now, and maybe the ribs too. The sacrum is that big flat bone down at the bottom that has an auricular surface, which is the auricular surface of the sacrum is the surface that articulates with the ilium. The ilium is part of the pelvic girdle. The other, remember I told you, the sacrum in the middle is part of the spine, but the other one's to the outside. So here's your lumbar vertebrae, here's L5, and then here's the sacrum down here, and
We don't have that one in.
It is on the next page. Yeah, but we just missed a couple of slides on ours.
well, you just have to jump around. I'm sorry. I don't know how that happened. So anyway, the sacrum has this shape, and remember that the sacrum is going to match up with this ilium. There's these two bones on either side that go around and form the pelvis. Okay? So it's this surface on the side that's called the auricular surface. It forms the sacroiliac joint. You may have heard that before. The sacroiliac joint is the joint between the sacrum and the ilium. I'll get the pictures in just a minute. There's also a thing on the inside called the sacral tuberosity, and you'll see what that does here also. Let's skip through this and let's look at pictures for a minute here. So here's the sacrum, and here is the top up here is what's going to articulate with that L5, the lowest vertebrae. So they call this the base of the sacrum. I don't know, base and the apex down here. The apex is just the pointy end. And instead of having spaces between the vertebrae, like they do in all the rest of the vertebrae for the nerves to come out, this has holes in it here for the sacral nerves to come out from the inside. There's an opening down through the top here. This is the sacral canal. It runs down to here. Here's where it opens at the bottom. So this is open from here up to there, which is like the same as the vertebral foramen over here on the rest of the vertebrae like that. And then their nerves are coming out through these foramen out to the sides, on either side. This bottom end of it is called the sacral hiatus, which is the bottom of it. Back in the day, back in the 20s and 30s and 40s, doctors used to put needles right up here into the sacral hiatus for ladies in labor and stick in local anesthetic and attempt to numb up all these nerves down here in order to numb up the area around the vagina when they're having a baby. It helped, but it didn't help much because most of the pain is coming from the uterus and higher, and so it didn't work all that great. And so really back in those days, a lot of ladies were simply put to sleep to have a baby. And the problem with putting ladies to sleep to have a baby is you're also putting the baby to sleep to be born. And so they come out really sleepy and they don't breathe well, and that led to lots of cerebral palsy and brain injuries and all that kind of stuff. But hey, they just didn't know any better. They were doing the best they could. Took a long time to get to where we are today with epidural anesthesia, which is really the way to go. We'll talk about that. Here's that auricular surface on the side of the bone, so it'd be over here and over there. That's where it attaches to the ilium to form the pelvis. It goes all the way around. This thing up in here is called the sacral promontory right here. Sacral promontory is important because that's one of the places that babies get hung up on when they're trying to be born, so to speak. It's one of the narrow spots in the whole trip out of mama's uterus. And no matter what you think about how there's too many C-sections done in the world, especially in America, let me just tell you, there's a whole lot that used to die. A lot of mamas and babies used to die in childbirth because the baby just didn't come out. We're lucky that problem has now been solved. We can do cesarean sections and take the babies out from the top. But for a long time, this bump right here, this sacral promontory, led to the death of hundreds and thousands of women and hundreds and thousands of babies because they couldn't get out. I told you my story about going to Boston, Massachusetts, and going through the cemeteries. It's just amazing how many guys had numerous wives, all of whom died, and numerous kids, all of whom died in childbirth or shortly thereafter. All right, let me go back to that now. So here's the auricular surface, is that side thick area. Tuberosity is the bump on the inside. The sacrum has the base and the ala that I mentioned, sacral promontory, and the apex is where the coccyx articulates with the sacrum.
Okay, so since you don't have 1, 2, 3 in this slot, where you decide on it, you just
Do I not care? I don't care, but I think you should.
I think you just skip from.
Well, they're going to be on the video.
She's talking about the ones that.
No, there's 3 other sacral slides. You have one talking about the median sacral crest, lateral sacral crest, but you didn't talk about those. This one, and then on the page behind it. If you flip it around, you see at the back.
Okay. I'll just say yes. Yes.
I have SI joint dysfunction. So
You have
that-
SI joint dysfunction? Yeah.
So that's just is it just the wearing down of the?
Well, the SI joint is pretty much fused. It shouldn't move much, but some people it's loose, and it does scrape on the sides And so when you walk and you put pressure on one side of your pelvis, and then you step on the other side and you put pressure on the other side, it kind of moves back and forth, and that gives you pain. Yeah. So anyway, just kind of a review of the spine. The cervical spine has 7 vertebrae. They're concave posteriorly. The thoracic spine has 12. They're each attached to a rib. They're convex posteriorly. And the lumbar spine has 5 more, and they're concave posteriorly as well. The sacrum is really 5 fused vertebrae together. Down there, it forms part of the pelvis. The SI joints are on either side of it, where the sacrum is attached to the ilium on either side. Coccyx is basically 4 more fused vertebrae down here at the bottom. About every 6 months or so, I would have some lady come in that had fallen on her butt and just landed right on her butt and broken her coccyx, maybe. We would do x-rays of it, but usually you couldn't really see a fracture. But they had probably gotten kind of disjointed and gotten torn away from the sacrum perhaps down there. But they were in a lot of pain, and that was a very, very slow thing to heal. You couldn't exactly put a cast on it, and nobody would recommend going in and just taking out those vertebrae, even though they don't really do much. But it's a very painful area, and people suffered from that. Try not to fall on your butt. A couple more things I would say. Between each 2 vertebrae, there is a foramina coming out the side called the intervertebral foramina. Now, when you look at this picture, it looks like, oh yeah, isn't that nice? There's a little hole coming out the side. But remember, it's not really a hole. I mean, it's the top half of the hole is created by the upper vertebrae. The lower half of the hole is created by the lower vertebrae, and only by there being 2 of them there does it really make for a foramen coming out the side. But that's the intervertebral foramen, and that's where all your spinal nerves come out. You have a set of nerves at each level, 31 levels, 31 nerves, 31 pairs of nerves coming out to service your whole body. Here's the intervertebral disc that you see. It's made up of fibrocartilage, as you know. The outer part of it is called the annulus fibrosus, and that's just the part that goes around and around and tries to hold all the rest of it in. It's made up of fibrocartilage, as you already learned about. The center part is called the nucleus pulposa, and this is the part that you want to stay in there. But if you get a rip in your annulus fibrosus out here, then the nucleus pulposa, which is almost half liquid, kind of comes leaking out. And when it comes leaking out, that's called a bulging disc or a ruptured disc. And that stuff comes out, and it pushes on the nerve that's coming out at that level. So that determines what symptoms you get. So if it's L3, you'll have pain going down the side of your hip down to about your knee, I think. And then when you rupture, if you have a ruptured disc at the L4, L5 level, it goes all the way down to your foot. And those people oftentimes end up getting surgery, although that's probably not a good idea. Don't ever get surgery on your back unless you've had 5 opinions and been treated with medicines and steroid injections for about 2 years. And I'm serious, because we pretty well studied back surgery and found that it does not work. 5 years later, people who've had back surgery have just as much problems as people who didn't have back surgery. Because every time you go into somebody's back, you create all this scar and other problems back there. So it's a difficult thing. Quick review here: cervical vertebrae have the bifid thing up here, and they have the extra transverse foramen out here on the side. There it is. There it is. They have superior articular processes where that articulates with the vertebrae above them, and they have inferior articular processes below them. This is the C1. Notice C1 doesn't really have a body. Remember, because it kind of borrows the dens from C2. It does have these 2 big superior articular facets these two facets right here articulate with the two facets that are on either side of the foramen magnum, which are on the bottom of your skull. Right next to the foramen magnum, there's two big smooth areas. Those two big smooth areas sit right on top of this and that, of atlas. Here's C2. It's got the dens, odontoid process. That's the other word I was trying to think of earlier that I couldn't. Odontoid process. So this is C2, and see it sticks up within C1, and C1 then can rotate around it very nicely, like this. So you all ought to get your C1 and get your C2 together and think about how they hook up together. Thoracic vertebrae have spinous processes that are not bifid. They have costal facets where they rub up against the ribs. The lumbar vertebrae are really big. Have you ever heard the term laminectomy? A lot of times if you look on the surgery schedule, it'll say Mr. Jones is set up for an L4, or say an L3, L4 laminectomy. Well, they got it in order to get to this part down here and pull that disc out. They have to get to it, and the way they get to it is they bite away this bone here called the lamina. They bite the whole lamina away, bite, get rid of that thing. Then they push the spinal cord over to the side with a retractor, and then they can, with their instruments, here's the back, skin of the back up here, then they can get through here and suck out all that disc that's left. Yeah, it's in a series of membranes called the dura mater, the meninges. There's 3 of them. Here's the sacrum, which is 5 fused vertebrae. Please notice that there's only 4 holes. 1, 2, 3, 4. Here's the coccyx down here at the bottom. That's called the sacral promontory. Sacral foramina. Here's where the sacroiliac joints are. Usually they're pretty much fused and they shouldn't hurt you, but in a lot of folks they're not. They shift a little bit. And these joints really loosen up during childbirth, by the way, to allow this whole pelvis to open up more. Not only does the SI joints open up, but also the symphysis pubis here in front, this piece of fibrocartilage here in front also opens up so that a baby's head can fit out through this hole down here. Coccyx is 4 little rudimentary vertebrae. If you look at the coccyx, I haven't seen one in the lab in a long time. Anyway, there's kind of a greater, this is a hyoid bone. I'm sorry, hyoid bone up in the neck. It has a greater horn and a lesser horn, a little body in the middle, kind of funny looking. It just hangs there in the middle of space. The sternum is in 3 parts. You need to know these. There's the manubrium. First of all, take and put your finger right up here at the top of your sternum. That's called the sternal notch. And whenever you're sticking needles and doing things in the neck, you always put one finger there so you know where you're at. That's this little notch right up here. And then come down from that about 1.5 inches, and you can feel this thing here, which is called the sternal angle. It's kind of a line that goes across that you can usually feel pretty clearly. That's the differentiation between the top part, which is called the manubrium, and the next part, which is called the body. And then at the bottom, there's the xiphoid process. It's right down here at the very bottom of your sternum. The manubrium is kind of interesting because the manubrium is the only bone that is attached to the arm. The clavicle comes in here and contacts with the side of the manubrium here, and the clavicle then attaches to the shoulder blade. The shoulder blade then attaches to the arm bone. But that is the only place where the bones of your arm are attached to the bones of your body. Wow, isn't that weird? The shoulder blade doesn't attach to any other bones back there on your back. It just lays on top of your ribs, but there's layers of muscle between it and other bones. I think this is a silly thing too. True ribs. They call 1 through 7 true ribs because they say these ribs attach in here to the manubrium. Well, why do you say this one attaches if you don't say this one attaches? But, you know, it kind of doesn't make sense. Anyway, the last 3 ribs down here, these 3 ribs, 8, 9, and 10, are called false ribs. The reason they're called false ribs is because they don't really attach to the manubrium. They attach to other cartilage here that then attaches to the manubrium. It's kind of bogus because this is all just cartilage, all of this whole thing down here. Yeah.
I thought the manubrium is attached with the clavicle, not with the.
It's attached to the first rib and it's also attached to the clavicle. Yes, thank you. The last 2 ribs are called floating ribs. If you're laying in bed tonight, roll over on your side and push in right back in here. You'll probably feel the tips of these 2 ribs. Right, there's one, and there's the other one right there in my back. So they're not attached at all. They're just kind of sticking out there on their own. They're not really floating. This is what a rib looks like. We have them in lab. You should look at them. The parts are easy. Articular facets. This is the place that articulates with the vertebrae back there. And this is the tubercle. This is the other place that articulates with the vertebrae back there. There's a little neck. There's an angle. There's a costal groove. The costal groove is something you should look for on every rib because just in this costal groove runs nerves and arteries. That's right.
Then you will know which one is right and left, right?
Yeah, you need to know which one's right and which one's left. The way you know is because the costal groove
In the bottom.
is always on the bottom. Yeah. Here's how they articulate back here. Here's the rib attaching there to the part of the body of the vertebrae, and the other part, the tubercle up here, attaching to that transverse costal facet out there on the transverse process. Just take and hold these together, and it'll make pretty good sense to you. This is called the costovertebral angle. Back there, the CVA. You'll see written in charts a lot. Patient has CVA tenderness. Most people that have CVA tenderness back in there have troubles with their kidneys, because your kidneys live right up under there. That's it. Okay, we're done. Next time we'll talk about the appendicular skeleton, and hopefully next time we'll have boxes of bones over here so you can hold them while we're talking about them.
What, in the classroom?
In the classroom. Try. I get in trouble for doing that. They don't like us taking anything out of the lab.